everyone, my name is Audra Kessler, and I'm a doc student in the Health Science and Exercise Leadership program at Penn West University. I'd like to welcome everyone to my Teaching Artifact 2 presentation, Dialysis Modalities in the Era of Rising Chronic Kidney Disease, Preparing Physician Assistant Students for Clinical Practice. So first, let's talk about the kidneys and what they do. So the kidneys have a lot of important roles in your body. One of the biggest things that they do is they act as your body's filtration or cleaning system. So the kidneys are responsible for eliminating waste products out of your body, and they also help to get rid of all the extra fluid that you have in your body. And so both of these things are excreted in the form of urine. The kidneys also play an important role in creating your red blood cells. They help to balance important electrolytes in your body, such as potassium, phosphorus, and calcium. They play an important role in your bone health, and they also help to regulate and keep your blood pressures under control. So as healthcare professionals, it's important to know some of the signs and symptoms of chronic kidney disease. Even if you aren't working specifically in a renal field, it's still important to be aware of these in your patients. So there are different stages of kidney disease, and depending on what stage they're in, you may see different types of symptoms. So someone in the early stages, they may say that they've had maybe changes in their urine frequency, so how often they are going. They may say that they notice that their urine might be foamy. They may complain of itchy skin, nausea, or decreased appetite. In the advanced stages, they may complain of difficulty concentrating. They may say they have numbness in their fingers or their toes. They can complain of muscle cramps, shortness of breath, and a lot of times these patients also say that they have bad breath or their breath can kind of smell like ammonia. However, with chronic kidney disease, one of the most common symptoms that we see is no symptom at all. So that's why with chronic kidney disease, it's so important to follow up with these patients and check their kidney disease status using diagnostics. So that's going to be through blood samples and through urine samples. So let's talk about who is at the biggest risk for developing chronic kidney disease. So the two most common things that cause chronic kidney disease are having high blood pressure and diabetes. So as a healthcare professional, it's so important that we're educating our patients on working to keep their blood pressures and their blood sugars under control, because the better controlled these things are, the healthier they are keeping their kidneys. If we see that high blood pressure and diabetes start to become uncontrolled, then it's going to cause kidney damage, which will eventually develop into chronic kidney disease. Other big things that we see that can cause chronic kidney disease are heart disease, obesity, age greater than 60. So as we age, regardless of if your health is well controlled, over time we see that the kidneys slowly start to decline just based on age. Individuals that have a family history of chronic kidney disease or someone themselves that has had an acute kidney injury in the past, these individuals have a higher risk of developing chronic kidney disease over time. And then tobacco use, and then any type of specific renal diseases. So a glomerular disease, certain autoimmune conditions, any types of infections, or cancer. So how do we diagnose kidney disease? Well, kidney disease is defined as abnormalities of kidney structure or function, and it must be present for greater than 3 months. So as I mentioned before, when it comes to symptoms, one of the most common symptoms is no symptoms at all. So that is why it's very important that you're following up with these patients for their well visits or their follow-ups to ensure that they are getting routine blood work done to be able to check their kidney function. So the two ways that we establish kidney function is through a urine test and a blood test. So the urine test is a UACR, which is a urine albumin to creatinine ratio, and this has to be greater than 30, or a blood test, which we're checking a GFR, which stands for glomerular filtration rate, and anything less than 60 is going to be suggestive of chronic kidney disease. This is a chart from the National Kidney Foundation that helps healthcare professionals make a diagnosis of chronic kidney disease. So as I mentioned, the two ways to do that is through a blood test, which is the GFR, and the urine test, which is the UACR. So on the left-hand side, you can see all the stages of a GFR. So anything that is greater than 90 is considered stage 1, so that is normal. Anything between 60 and 90 is stage 2. Anything below 60 is where we are concerned for chronic kidney disease. So, and anything below 60, there's 3 different stages. So there's stage 3, stage 4, and stage 5. And stage 3 is broken down into stage 3A and 3B. So you can see on the chart here where the numbers lie. And then on the right-hand side, you can see the albuminuria categories on the top, and those are broken down into 3 different categories, A1, A2, and A3. So again, anything that is greater than 30 is where we're going to see concern for chronic kidney disease. So, and as you can see by the chart, things that are in green are things that we are not worried about, that we would consider normal. And then as the numbers progress, those blocks turn red, and then that's where we become more concerned for more severe chronic kidney disease and even kidney failure. So when is it appropriate for a patient to be referred to a nephrologist? So the KDIGO guidelines suggest that someone is referred when either their GFR is reduced, so a GFR that drops below 30, significant proteinuria, which means their UACR is greater than 300, if we see a rapid progression or a rapid decrease of their GFR from 20 to 30% over a very short period of time, or if we're seeing a patient who has uncontrolled blood pressure or their blood pressure is high, even though they're on 4 or more blood pressure medications. So in general, the rule of thumb is if we see a patient in stage 3, so whether it's 3A or 3B, so it's recommended that you are referring that patient to a nephrologist to be cared for. And pretty much the goal of this is because the earlier a patient is referred, the earlier that the kidney doctors can kind of intervene and work to slow down their chronic kidney disease progression. So we already talked about the kidneys, what they do, what their function is. We discussed chronic kidney disease, how it's diagnosed, what are some signs and symptoms, and how we stage it. So next, I really want to move into talking about dialysis options. So for the remainder of the presentation, that is what we will be focused on. So if you look back to this chart here by the National Kidney Foundation, the stages that we're really going to focus on are going to be stage 4 and stage 5. So these are the stages when we really want to start talking to patients about what their dialysis options are, if they are interested in a transplant, and really preparing them to start dialysis. So anytime a patient gets to stage 4, which means their GFR or their percentage of kidney function is less than 30, this is when it's important to start having those conversations with patients. Because once those patients get to stage 5, that's when we start to see them needing to actually start dialysis. So again, stage 4 is when we're really going to talk about what the dialysis options are, and their options are going to be hemodialysis, peritoneal dialysis, and transplant for those patients that are eligible. And then stage 5 is when we were going to see patients needing to start dialysis based on their symptoms, because once they truly get to stage 5, that is when we start to see some of those physical symptoms that we mentioned earlier. So with dialysis in general, the goal or the purpose of it is to function as a kidney. So dialysis is going to work to filter waste products out of your body. It's going to help remove all the extra fluid that's in your body to help control your blood pressure, and it's going to help balance your electrolytes. So as I mentioned, there's a couple of different types of dialysis. So the first one we're going to talk about is hemodialysis. And with hemodialysis, this type of dialysis works by cleaning your blood outside of your body. So the way this works is you could go to a dialysis center to have this done. Some patients also can do this at home. But what happens is 2 needles are placed in your arm. Those needles are connected to tubing, which is then connected to the dialysis machine. And essentially what happens is the first needle takes the blood out of the body, puts it in the dialysis machine that acts like a giant kidney. And so your blood goes in there and it gets all clean. And then once it's clean, it's returned to you through the second needle. And essentially that process is repeated over and over until all of your blood has been cleaned. So one dialysis treatment typically takes about 4 hours. So essentially for 4 hours, your blood is being cycled out of your body into the dialysis machine and then back into your body until it is all clean. So what does that look like? So this is a nice picture here of that process. So again, you can see here there are 2 needles in the arm. The red one removes the blood from the body. It goes up into the dialysis machine and it gets clean. And then in the blue needle, you can see that it returns the blood to the body. And again, this process is just repeated over and over for 4 hours. Here are 2 more pictures of what hemodialysis looks like. So I always like to include kind of like a cartoon version and then a real life version so everybody can kind of really get an idea of what dialysis truly looks like. But again, you can see here it is a patient, and typically you just sit in a chair next to a large dialysis machine, and essentially you can see the blood is being removed from the body, being cleaned, and then returned to the body. With hemodialysis, patients receive 3 dialysis treatments a week. So typically they follow either a Monday, Wednesday, Friday schedule or a Tuesday, Thursday, Saturday schedule. And as I mentioned, each treatment lasts approximately 4 hours, give or take a little bit, depending on the patient's body weight or body mass. And again, as I mentioned as well, you could also do home hemodialysis as well. Patients can be taught how to do this process themselves, or they can have a spouse or a caregiver do this at home for them as well. In order to do hemodialysis, we need some way to access the patient's blood. And the veins that they have right now, they're too small and they're too weak to consistently use 3 days a week to access blood for dialysis. So what we need to do is create what's called a hemodialysis access. And there's essentially 3 ways to do this. There is a arteriovenous fistula, an arteriovenous graft, or a tunneled hemodialysis catheter. For patients that are doing hemodialysis, the goal is for them to have an AV fistula created, which is essentially a permanent access created in their arm using an artery and a vein. So again, the veins that you have right now in your arm, they're too small and they're too weak to be able to use over and over for dialysis. So what we need to do is we need to create a large blood vessel that is big and strong that we can use over and over for dialysis. So what they call that is a fistula. So what they do to create a fistula essentially is they take an artery and a vein and connect them together. So veins are smaller blood vessels that are under less pressure, whereas arteries are larger blood vessels that are under high pressure. So what they do is they connect an artery to a vein, and then what happens is over time, very slowly, that vein starts to get bigger and stronger because it's now connected to an artery. So very slowly, essentially, that artery pumps up that vein and makes it nice and big and strong. And that process can take several weeks to months for that to occur. And once that vein is nice and big and strong, then that's what they call the fistula, and then that's the blood vessel that they use for dialysis. In this picture, we can see what a fistula looks like. So in the picture on the left, we can see the blood vessels that are used and the blood flow. So the smaller red blood vessel is the artery, and the blue blood vessel is the vein. So you can see that the blue blood vessel and the red blood vessel have been connected right in the forearm. So there's two common areas where you can create a fistula. There's a radiocephalic fistula, which is going to be in the forearm, and a brachiocephalic fistula, which is going to be created more in the upper arm. So in this picture, we can see that it takes place in the forearm. So you can see that those blood vessels, the red and the blue, have been surgically anastomosed or connected together. And over time, the high blood pressure of the artery slowly pumped up that vein and made it nice and big and strong. So that's why we see in the picture that that blue blood vessel is much bigger than the red one now. And then so for dialysis, those little yellow tubes indicate where the nurse will put the needles. So the nurse puts the 2 needles into that vein or into that fistula, and one needle takes the blood out. The blood goes into the dialysis machine, gets all clean, and then the other needle returns the blood back to the body. On the right-hand side, you can see what a fistula looks like in real life on a real patient. So with fistulas, because the veins do get larger, sometimes you can see the fistula under the skin. So that's why in this picture, we see that you can see the bump or kind of follow where the vein goes under the skin. The reason we want patients to get an AV fistula is because they are the lowest risk of infection and they last the longest, so they're less likely to get a blood clot in them. The disadvantages of having a fistula is it is a long process. So once a patient sees a surgeon and has the procedure where they connect that artery to the vein, that process of pumping up the vein to make it nice and big and strong can take 2 to 4 months. So this is why this is so important that we refer patients to nephrologists or to kidney doctors early. That way, if a patient does choose to do hemodialysis, we can then refer them to a surgeon and they can have a fistula created in their arm well before them ever needing to actually start dialysis. The goal is really for all patients who are doing hemodialysis to get an AV fistula created. Another option for hemodialysis is to have an arteriovenous graft placed instead of having an AV fistula created. So the reason that someone would have a graft instead of a fistula is if they determine that a patient has very, very poor or very, very small veins that they don't think would successfully develop into a nice, big, strong fistula, then they can put in what's called a graft, which essentially works the same as a fistula, only instead of connecting the 2 blood vessels directly to each other, they put in a graft, which is essentially a little piece of plastic, and they connect one end to the artery and one end to the vein. So then when you actually get dialysis, instead of putting those needles directly into the artery or the vein, you're putting those needles into the graft. So the good thing about grafts is they do, just like a fistula, they have a very low infection risk, and they do take less time to mature because we're not waiting on the actual vein to grow and develop. Disadvantages of a graft is there is a higher risk of clotting with them. As a healthcare provider, it's very important that you yourself know how to care for a fistula or graft and to be able to educate your patients on how to care for them. So one of the first things is educating your patients on making sure that their graft is working. So if you have a patient that has a fistula or graft in their arm, if they take their opposite hand and lay it lightly over top of it on the skin, they should feel a vibration. And so that vibration is that blood going very quickly through that blood vessel. So by checking it every day, they can confirm that they can still feel that vibration. If for some reason that they don't feel it, or if they notice a change over several days, if that vibration is not as strong, that could be a sign that there is a blood clot starting inside that fistula or graft. So again, it's important to teach them to continuously check it each day to make sure they can still feel that vibration and that there's no changes in it. We also want to tell patients never to wear tight clothes or tight jewelry over that. So if someone has a fistula in their forearm, they shouldn't wear a tight watch over top of it. We also want to encourage them not to carry anything heavy. So we always tell patients, don't hang a heavy purse on your arm, or if you're carrying groceries, don't try to hang 10 bags of groceries on your arm and carry them in. Anything that's going to very strongly compress that blood vessel, we want to try to avoid doing. And then two of the biggest things that we tell patients are to never ever get blood pressure checks in the arm that you have a fistula, and never get blood drawn. So again, when you have a patient come to the office, it's always very important that you ask them, do they have a fistula in their arm? Because you never want to take blood from that fistula, and you never want to take blood pressure in the same arm that has a fistula. The third hemodialysis access option is a hemodialysis catheter. So this is used when a patient needs to start dialysis right away and they have not had a fistula or graft placed. So essentially, if a patient needs to start dialysis emergently, then they can have a tunneled dialysis catheter placed and they can start dialysis the same day. So a tunneled catheter essentially is placed into the internal jugular or the subclavian. It goes through the superior vena cava and then goes down into the right atrium of the heart. So although these catheters are good because a patient could essentially get a catheter and be able to start dialysis the same day, they have a very high risk of infection because obviously you have a tube that's going straight into your large blood vessels and down into your heart. So because of that, they run a really high risk of infection. They have a high risk of getting a blood clot. And patients that have catheters, unfortunately, have a higher risk of hospitalization. So someone that does have a catheter, if they do have to get one in an emergent situation and start right away, we have them get that, but we also then send them to a surgeon so that they could still have a fistula or a graft placed, so that eventually, once that fistula or graft are developed and ready to use, then they can remove the catheter. So ideally, catheters are only going to be used short term to get dialysis. Because of the high infection rate, these catheters cannot get wet, so they cannot be exposed to water, so patients cannot shower with them on. So if you have a patient that has a tunneled catheter, patient education is very important because it's very important to educate them that they're not allowed to do those kind of things because it really increases the risk of infection for them. This is a picture of what a tunneled hemodialysis catheter looks like. So you can see where it goes in under the skin and then down into those large blood vessels and then down into the heart. And then you can see it has two tubes connected to it, so a red one and a blue one. So one is essentially going to take the blood out of the body, and then it's going to be returned through the other tube. The next type of dialysis that we are going to talk about is peritoneal dialysis. This type of dialysis uses the lining of the abdomen, which is called the peritoneum, to filter the blood inside your body. So hemodialysis, the kind we just talked about, that type of dialysis cleans your blood outside of your body in a dialysis machine, whereas peritoneal dialysis, which we're going to talk about now, that type of dialysis cleans your blood by putting a clear liquid called dialysate into the abdomen. So for this type of dialysis, patients have to get what's called a peritoneal dialysis catheter, and that is placed into the abdomen. And then what the patient does is they take this clear fluid, which is called dialysate, and they put that into the tube. And that fluid then goes into the abdomen via that catheter. And what that fluid does is it sits in the abdomen and it absorbs extra fluid and it cleans the blood through osmosis. So what it does is it absorbs waste products from the blood. Once it's done doing all of its absorbing, then that fluid is then removed from the body. And then the process is repeated. So with this type of dialysis, there's two ways to do it. There is CAPD, which is called continuous ambulatory peritoneal dialysis, or automated peritoneal dialysis. And we're going to talk about both of them. So this is just a nice visual of peritoneal dialysis. So as you can see in the picture, the first step is you have a full bag of dialysate fluid, and then that fluid goes through the tubing, and as you can see here, the blue liquid in the picture, that represents that fluid going into the abdomen. And then what that fluid does is it sits there and it's cleaning and it's absorbing all the waste products in the blood and in the body. And it does it using the lining of the peritoneum. And then the second picture, you can see now that that fluid has been sitting in there, it has turned yellow. So what that means is it has now absorbed all of those waste products and done its cleaning. So now that fluid needs to be emptied. So then we see then that fluid will come back out through that catheter and go into an empty bag for waste removal. So as I mentioned, there are two different ways to do this. This can be done using CAPD or APD. CAPD, or continuous ambulatory peritoneal dialysis, this type of dialysis can be done at home by the patient. So what happens is this patient will have an IV pole. They will be provided with these bags of fluid of this dialysate solution. And essentially what the patient does is they take a clean bag of fluid, they hang it on the pole, they connect the tubing to their catheter in their abdomen, and essentially by gravity, all of that fluid will slowly run into their abdomen. So that process usually takes anywhere from 10 to 20 minutes for a full bag to then filter into their abdomen. And then what they do is then they disconnect the tubing and they go about their day. And that fluid stays in their abdomen for a few hours. After a few hours, now that that fluid has had time to absorb and clean, now it's time to empty the fluid. So to empty, what they do is they take an empty bag of fluid, they put it on the floor, they connect tubing to their catheter, and then again by gravity, all of that fluid will run out into the bag on the floor. Once all the fluid has been removed from their abdomen, they take a new clean bag of fluid and they repeat the process. And they connect it to their tubing and they let all the clean fluid run in. So again, now their abdomen is filled with clean fluid and it can start the cleaning process over again. So again, this is a type of dialysis that a patient can do at home. It's a manual process that uses gravity that essentially has the patient put clean fluid in and take dirty fluid out, and essentially just continuously repeating that process. Every time a patient removes dirty fluid from the body and then puts new clean fluid into the body, it's called an exchange. And typically a patient will do 3 to 5 exchanges a day, depending on their body mass or their size. The second type of peritoneal dialysis is called automated peritoneal dialysis. So this is a type of dialysis that uses a machine called a cycler that does the exchanges for you. So essentially what this machine is doing is it is putting new clean fluid into the body and then taking dirty fluid out of the body. And essentially this process is done at night while the patient is sleeping. So the first type we talked about, which is the CAPD, where we're using gravity and the patient is doing the exchanges, that is typically done during the day. So the patient has that fluid in their abdomen while they're going about their daily life. This type of dialysis, the automated peritoneal dialysis, this one is done at night while a patient is sleeping. So essentially the cycler, the dialysis machine, is putting the fluid in and taking it out and putting it in and taking out, all while the patient is asleep. This is a picture of what it looks like. So again, the patient is sleeping. There is tubing connected to the catheter, which is then connected to the dialysis machine. So the machine essentially heats up the fluid. It puts the fluid into the abdomen, and then once it is done cleaning, the fluid is then removed and you can have it set up so that when the fluid is removed, it either goes into a bag, an empty bag, or a lot of patients actually connect a drain line, which is another tube that literally goes directly into their toilet. So in the morning, all of that, they see all the fluid that has gone into their toilet, and they essentially just flush it down. This is a picture of what a cycler looks like. So you can see the fluid bag on the top lays there to get warm, and then the tubing beneath it is connected to the patient, and then that puts the fluid in and takes the fluid out of the body repeatedly at night while the patient is sleeping. This is what a peritoneal dialysis catheter looks like. So for this, a patient will see a surgeon, and the surgeon will surgically place this into the patient's abdomen. With this type of catheter, because it's going into the abdomen and not directly into a bloodstream, there is a lower risk of infection compared to the hemodialysis catheter that we talked about. So with this catheter, you can get it wet, so patients can take showers with them. However, we do try to tell them to refrain from going in dirty bodies of water, such as bathtubs, hot tubs, lakes, and rivers. But again, this is kind of what it looks like during the day when if it's not being used, it's covered with a large patch. Again, so it doesn't rub or bother the patient or like rub on their clothes. Now for some not so fun facts. So I always like to include some statistics in my presentation, really so it gives the students a better understanding and a better appreciation for how many patients and people these chronic conditions impact. So in overall, chronic kidney disease affects about 35 million Americans. As we mentioned in the presentation, high blood pressure and diabetes are going to be the two most common causes of chronic kidney disease, and these two things continue to grow over time. We're seeing over 119 million Americans with high blood pressure, over 40 million Americans with diabetes, and over 800,000 individuals with end-stage renal disease, so those needing dialysis. So again, these are huge numbers, and unfortunately, we just continue to see these numbers increase. The World Health Organization projects chronic kidney disease to become the 5th most common chronic disease by 2040. So again, as we continue to see these chronic diseases increase over time, we're going to see the need for chronic kidney disease management and the need for dialysis in patients. We're going to see those continue to increase over time. So it's essential and it's important that these future healthcare providers are provided this information. In PA programs, there is an NCCPA content blueprint. As of now, nephrology is only 5% of the blueprint. So that means that only 5% of the boards contains questions about chronic kidney disease and renal. So again, it's so important that we are putting more focus on that area because, you know, when students see, oh, only 5%, I don't have to really focus that much on that because there's not going to be a lot of questions. It's really unfortunate because, again, we're seeing so much chronic disease circled around chronic kidney disease. So again, it's so important that we're educating these future healthcare providers on chronic kidney disease management and really what the dialysis options are so that they are aware of it and they can better care and manage for this patient population. So take-home messages from this presentation. It's important to know that renal is everywhere, regardless of what area of medicine you go into. Even if you don't specialize in renal, it's important to know about chronic kidney disease. It's important to know about dialysis options. If you are someone that goes into orthopedics, you may think you don't need to know about renal, but what if one of your patients breaks their arms and they need casted and they have a fistula in their arm? Can you put a cast over their fistula? Again, at that point, yes, renal is going to be important to you. So again, you don't need to specialize or know everything there is to know about renal, but it's important to know the basics so you can have a better understanding and a better care for your patients. It's important to realize that it's a growing epidemic, as you can see by those previous numbers, these chronic conditions are continuing to grow, and as they continue to grow, we're going to have more need for understanding and more need for treatment of these patients. It's important that we're referring to these patients early to nephrologists so they can kind of slow down that management. Again, no blood pressure, no blood draws in the access arms, can't get a hemodialysis catheter wet. Know that there are different dialysis options, and most importantly, know your resources. As I mentioned, you don't need to be a specialized in renal. You don't need to know everything about every aspect of medicine, but it's important to know who your resources are. Those are the people that you're going to reach out to for help and for information, because working collaborating with colleagues and working interprofessionally is the best way to really care and to treat patients. These are my references.